Imagine looking at an ECG and predicting which electrolyte is abnormal before even seeing the lab report. A tall peak T wave, a long QT interval, or a mysterious U wave can literally mean the difference between life and death. In this video, we will learn how potassium, calcium, magnesium, and sodium disorders affect the ECG and most importantly, how to treat them. By the end, you will be able to recognize these patterns with confidence. So let us begin. Hyperkalemia is one of the most dangerous electrolyte abnormalities because severe cases can rapidly progress to cardiac arrest. The earliest ECG sign is tall, narrow, peak T waves. As potassium levels rise further, the PR interval becomes prolonged and P waves begin to flatten or disappear. The QRS complex widens and eventually a sine wave pattern develops, which can deteriorate into ventricular fibrillation or asystole. Remember this sequence: peaked T, peak disappears, and QRS widens. Treatment occurs in three steps. First, stabilize the cardiac membrane with intravenous calcium gluconate. Second, shift potassium back into cells using regular insulin with glucose, nebulized salbutamol, and sodium bicarbonate if acidosis is present. And thirdly, remove potassium from the body using diuretics, potassium binders, or hemodialysis, which is the definitive treatment in severe cases. When potassium becomes low, the ECG changes are almost opposite to the hyperkalemia. The T waves become flattened, ST depression develops, and a prominent U wave appears, which is a classical finding. Severe hypokalemia may prolong the QT interval and predispose patients to ventricular arrhythmias and torsade de pointe. Think of this phrase: low potassium U wave says hello. Treatment depends on severity. Mild cases can be treated with oral potassium supplements. Severe or symptomatic cases require slow intravenous potassium replacement under ECG monitoring. Magnesium deficiency should always be corrected because potassium levels are difficult to normalize without adequate magnesium. Hypercalcemia shortens ventricular repolarization. The hallmark of ECG finding is a shortened QT interval. Patient may also develop bradycardia, AV block, or ventricular arrhythmias in severe cases. Remember, high calcium equals to short QT. Treatment starts with aggressive intravenous hydration using normal saline. Once hydration is achieved, loop diuretics may be used. Calcitonin provides rapid reduction in calcium levels, while bisphosphonates provide a long-lasting effect. Ultimately, treating the underlying cause is essential. Low calcium prolongs ventricular repolarization. The characteristic ECG finding is a prolonged QT interval caused by ST segment prolongation. Severe hypocalcemia can predispose patients to torsade de pointe. An easy way to remember this is low calcium means long QT. Treatment includes intravenous calcium gluconate in symptomatic patients, followed by oral calcium supplements and vitamin D replacement if needed. Continuous ECG monitoring is recommended in severe cases. Excessive magnesium slows electrical conduction in the heart. ECG findings include prolonged PR interval, widened QRS complexes, heart block, and severe bradycardia. In advanced cases, cardiac arrest may occur. Think of high magnesium slows everything. Management begins with discontinuing magnesium-containing medications. Intravenous calcium gluconate acts as an antidote. Hydration and loop diuretics enhance magnesium excretion, while dialysis is reserved for severe cases or renal failure. Low magnesium is an important cause of ventricular arrhythmias. The ECG may show prolonged QT interval, T-wave inversions, ST depression, and prominent U wave. One of the most feared complications is torsade de pointe. Remember, low magnesium causes rhythm trouble. Treatment consists of intravenous magnesium sulfate in severe or symptomatic patients and oral magnesium supplements in milder cases. Associated potassium and calcium abnormalities should also be corrected. Unlike potassium or calcium disorders, hypernatremia has no specific ECG findings. Patients often develop sinus tachycardia due to dehydration. Severe hypernatremia may result in non-specific arrhythmias, and treatment focus on correcting the water deficit. Free water replacement can be given orally or intravenously using hypotonic fluids such as 0.45% saline or dextrose solutions. Sodium correction must be slow because rapid changes may cause cerebral edema. Hyponatremia usually affects the brain more than the heart, and ECG changes are generally non-specific. Severe cases may produce bradycardia or arrhythmias. Treatment depends on severity. Mild chronic hyponatremia is managed with fluid restriction and treatment of the underlying cause. Severe symptomatic hyponatremia, especially with seizures or altered consciousness, required 3% hypertonic saline. Remember that sodium correction should always be gradual to prevent osmotic demyelination syndrome. Let us summarize the most important points. Hyperkalemia gives peak T waves, hypokalemia produces U waves, hypercalcemia causes a short QT interval, hypocalcemia causes long QT interval, hypomagnesemia predisposes to torsade de pointe, hypernatremia and hyponatremia have no characteristic ECG changes. If you remember these 6 facts, you will recognize most electrolyte abnormalities on ECG. Electrolyte disturbances are among the few reversible causes of fatal arrhythmias. Understanding their ECG changes allows clinicians to diagnose and treat patients quickly and effectively. If you found this video helpful, please support the channel by liking this video, sharing it with your friends and colleagues, and subscribing for more high-yield medical content. Thank you for watching.